very, very happy to be here. My background, first of all, what I want to say, make perfectly clear, is that I have absolutely no medical training. My background, the BA, is in social cultural anthropology, and it's an undergraduate degree from Canada. The Masters and the PhD are in forensic anthropology, and the PIG dip was a one-year postgraduate course training in gross human anatomy. And one of the things I do at the moment is I work as a demonstrator on the main campus, guiding the medical, primarily dental and medical students, but some forensic anthropology students through their full cadaveric dissection. I'm going to show you some images, probably about 4 or 5 seconds per image, facial images. A before and after image. And these are some of my subjects. Female to male, FTM. This was original research, never been done before. There is no documentation of anyone looking at female to male, or for that matter, male to female transsexual faces. It combined social, forensic, and some medical anthropology. FTMs, in comparison to MTFs, male to female, are probably a much under-examined population. There are two crucial elements to this research. The first one is that I am an embedded researcher. So by that I mean that I am a female to male transsexual. I'm part of the population group which was under study in this research. The other thing is that you're going to, I'm sure many of you are going to be quite deeply appalled at some of the flaws in the method employed in the research, but it was, in actual fact, the only possible way to do it, and some excuse has to be made for the method in that regard. Because the results were, to some extent, a bit inconclusive, or not exactly what I had expected or desired, this ended up being a piece of exploratory research. But as exploratory research, I think it holds its weight because, as I said, it's original. I think that what it does is it opens a pathway. It opens a lot of room for potential future research, particularly into female-to-male transsexuals as opposed to male-to-female. The little blonde darling on the left, your lower left, is me. So the objectives of this presentation today are, I'm going to give you a very brief summary of the theory, the methods, and the results of the research, and I've drawn out some aspects of the biological profiles of the subjects because I thought that would be particularly of medical interest. And I'm going to take a slight side path, and I'm going to talk about the perception of ambiguous face, sex / gender, as it may pertain to transsexuals themselves. Most of this is specific to female-to-male transsexuals rather than male-to-female. The quality of life is something that, the phrase the quality of life, including these aspects, is something that clinicians tend to focus on as a way of helping them make decisions and do an analysis of the person that's presenting to them requesting medical assistance. A female-to-male transsexual, this may be a bit redundant for many of you, but is an individual who was I mustn't walk away from the mic. I have a terrible tendency to wander. A female-to-male transsexual is someone who was assigned female sex at birth, but feels that there is an inner identity which is in conflict with the assigned sex. and that inner identity is usually perceived as masculine on a graded variant, and is called gender. I have renamed GRS and SRS as SARS, and I've done that for the simple reason that nobody changes sex. So sex reassignment surgery to me is a complete misnomer and very confusing. I think it's certainly very confusing to people who know little to nothing about transsexualism. Sex is not the same thing as gender. They're two different things, and they are constantly conflated in the literature and in general discussion, which is also very confusing. So I'm making that very clear here today. And gender, of course, is not binary. It is for some people, but for many it's not. And for the younger generation who are now emerging, gender is definitely not binary. So the project was to document the transition from a female to a male facial appearance and see if I could identify any patterns that could be predictable. There were 25 subjects. Background theory is supported primarily by the fact that faces, like the rest of the body, are responsive as biological units to hard and soft tissue changes. In this particular instance, to hormones, although the other two factors are, of course, very relevant. And in this case, they're exogenous hormones. And the individuality of faces, which is very much at the centre of this project, it's not simply about the sex of the face, but it's about the individuality of the face, is very much dependent upon the validity of craniometric studies. So very, very slight differences in bone morphology and morphometry will individuate a face, 1 in 6 billion. So the method was, first of all, a qualitative analysis, a comparison of the morphology using descriptors of facial features with a standardized lexicon. You have a before and after. Can you see the faces very clearly? It seems a bit sort of shadowy or smoky. It's great on my screen, but it's not so great on that screen.
Turn the lights down a bit, right?
Okay, thank you. So that was done using photographs. Sorry, I'll go back for a second. I got distracted. That was done using photographs. So the subjects needed to provide me with photographic images from their pre-transition period of life. And then I took photographs of them when they came to me as subjects. So the comparison of morphology using facial feature description was done primarily using the photographs.
Making it worse.
Yeah, that's all right. I'll just keep going. I used an infrared surface laser scanner to produce a 3D model of their post-transition face in addition to the photographs that I took of their post-transition face. And this was simply so that I could orient the post-transition image as closely as possible to the angle and the degree of the face to the camera of the pre-transition image. This is the only way to get any kind of quantification. So the superimposition, on the left you see that's my face in the photograph, but this is freeform 3D modeling program, and that's a scan of my face, and that's in 3D modeling freeform program, that's my face being slowly brought into approximated angle with the pre-transition photograph. On the right-hand side is the image brought out of freeform modeling and put into Photoshop, very simply, with the superimposition as you see it there. That allowed a quantification process. So I was able to make landmarks and then do a comparison between the pre- and post-transition morphology and morphometry, mostly the morphometry. They were calculated as proportional values, of course. Yes, that's another image of the superimposition at work. So there were a number of problems with this method. There is no control. So that's a serious thing, and it affected the ability that I had to differentiate between the effects of aging and the effects of testosterone, at least in part. There were no subsurface images. And that was something that initially I had wanted to get at. I wanted, coming from a background of forensic anthropology and training in osteology, I really felt that there were changes that occurred in the craniofacial bones, and I wanted to get at that, and I was not able to. I was only able to get at the surface. It's a very small subject group. and that makes it very difficult to generate useful statistics. Also, because this was a PhD, the parameters of the longitudinal nature were limited. There were technical limitations, which I will go over very briefly. When you're using photographs, one of the problems I had is that photographs, as you can see in the bottom image, absolutely useless, and in the upper right image, part of the face is obscured. Also, there's an expression which is too extreme. So landmarks were difficult to identify in many of the images, and many of the images were simply not usable at all. Critical facial areas ended up obscured. When you're using photographs, I had no idea how the photographs were taken. So there's no idea about the distance from the person that the camera was at, angle, perspective. All of that was information I didn't have. And you always get distortions which have to be taken into account. The 3D scanner was the only way to do a comparison, but the 3D scanner had a lot of problems. It wasn't as portable as it should be. It's a handheld unit, so it's very susceptible to the person who's operating it. So any kind of shaking, any kind of tremor, any kind of variation in the distance from the object to being scanned. The scanner didn't like metal. It didn't like magnetic forces. It didn't like hair. It didn't like grease. It didn't like shadow. There were a lot of problems with it. There are other issues as well. For transsexuals, I think visibility is always a difficult thing to negotiate, and that's one of the reasons it was so difficult to find subjects. For many of these people, pre-transition images simply didn't exist, and that's because what tends to happen is there's a significant number of transsexuals or transgendered people for whom family is a thing of the past. They can't get access to photos. Perhaps mum and dad have them, but they can't go back and ask mum and dad for those photos. For many of the people, they'd simply destroyed every pre-transition image they had. They no longer existed. There's a certain degree of sensitivity about physical appearance, and for me there was a bit of a problem with subject location. I had to take the scanner very often to them, so that meant travelling abroad, travelling throughout the UK, and the scanner didn't like to travel. There's also an element, too, of a mistrust amongst some transsexuals in particular of scientific and medical people. And I found that despite the fact that I had bright blue T-shirts made up when I would go to conferences with FTM plastered across the front of my chest and "He needs your face" across the back, that they didn't recognize me as being one of them, so to speak. They thought I was a medical person or a science researcher, and until they actually realized that I was one of them, they did not want to talk to me, they didn't want to come and read my poster, they certainly didn't want to volunteer as subjects. So, briefly, some results. The average age of the subject was 39, range 23 to 59 years, most of them falling into the 40 to 50 years age bracket. Subject age at start of testosterone use was 30 years, range 17 to 48 years. I think one of the important things to recognize... One of the important things to recognize about the age of subjects is that it looks like they're going to start presenting earlier and earlier. And in the UK, children and adolescents are the ones that are presenting, and that's doubling every 5 years. The duration of time on testosterone in this subject study was 8.6 years, 60% of them between 3 and 8 years. It appears, although it's not verifiable yet, that the effects of testosterone in many of the body systems are cumulative, and I believe from experiential knowledge that this is true. It's one of the things about the amount of time that I had to collect data. Ideally, data would be collected on this group a year after beginning testosterone, and then I think probably every 2 years after that for up to 10 or 15 years. and that would be ideal. The form of delivery is most commonly the injectable form, and one of the things that came out of looking at the information that subjects offered me was that the dosage regime for testosterone is very, very variable. And the next slide deals with that in a bit more detail. In terms of gonadectomy, 56% of subjects had a gonadectomy. This is a table from one of the subjects, and this hormone regime spans 9 years, and you can see from the dates listed on your far right that there's a lot of chopping and changing. I'm not sure how this affects the rate of change and whether or not it causes physical symptoms of discomfort, but it's something I think that needs to be looked at as an aside. I've brought in some information that came out of my ancillary reading. The physical effects of exogenous testosterone are quite clear, and these are well documented. Higher muscle mass tends to lead to changing in the bone mass and bone geometry in FTMs. It appears the longer the use, the more that is so, the more that is the case. And it's specifically about increased cortical bone area and bone size and increased trabecular volume, bone mineral density. The body composition changes are, as you would guess, fairly easy to look at. Apart from the higher muscle mass, you get a decrease in the body fat mass, and so the waist size increases and the hip size decreases. You get a change in the basic body shape. Menstruation ceases, you get the growth of a microphallus from the clitoris, and there's body hair, facial hair appears, and male head hair loss. Voice tone and depth changes to a male range, and the skin goes through a number of changes, which is a lot more obvious in people who are Caucasian rather than not Caucasian. You get an increase in visceral fat, body weight, red blood cell count goes up, and 3 proteins implicated in vascular function and other important functions are affected. There's a decrease in the high-density lipoprotein, the good cholesterol, but overall there are several things which are unchanged, and these unchanged elements seem to lead a number of clinicians to think that overall androgen effects on cardiovascular risk, which is something that tends to be a concern, are not universally negative. And the cardiovascular events, hormone-related cancers or osteoporosis may be of more limited concern than has previously been thought. Back to results. So, in a qualitative sense, looking at the pre- and post facial images, pre-transition, about 25% of the subjects were assessed as being male-appearing, or perhaps, if you like, androgynous. And post-transition, 96% of them most definitely appeared male. 96% of them, not coincidentally, had beard shadow or facial hair. And 52% had male pattern balding, and 48% had noticeably coarser skin texture. The confounding factors in the research, which was hampered by the fact that there were no controls, was a change in adipose tissue, so an increase or decrease in weight, and the effects of aging. Particularly the inferior migration of adipose tissue into the lower part of the face. So what basically happened with the majority of the faces pre- and post-transition is that post-transition they got wider. Some of them got a bit narrower, but by and large they got wider, and they got wider in the mid-face, the upper jaw and the lower jaw, and the chin. In some instances, the lower jaw and the chin got narrower, and the mid-face and the upper jaw got wider. And even though the lower jaw and the chin got narrower because of generally a decrease in the fat and a coarsening of the skin and an increased turgidness in the musculature of the face, particularly around the oral aperture, meant that even though they were narrower, they still looked masculine as opposed to feminine. The frequency of the changes were recorded: upper jaw 76%, mid-face 72%, and lower jaw 52% widening. And those were the basic patterns. There were a small number of them who got narrower throughout the face, but they were in the minority. So, as you can see, these are small increments of change. Small increments have a large effect. That is certainly true in craniometric studies when you're doing individual faces, when you're trying to individuate faces one from the other. Very, very, very small increments of difference make for an entirely different face. The measurements that allowed me to look at facial height changes were small, and that was because of the limits of the pre-transition photographs. The changes that occurred in facial height, particularly mid and lower face, correspond to normal aging changes, mostly around the piriform aperture and in the upper jaw. So those correlate with non-transsexual populations as they age. There's nothing spectacular about that at all. One of the things that I did notice, and that showed up particularly, laser pointer, showed up particularly in the 3D scans, is this increased rugosity around the musculature around the oral commissure. So in the pre-transition images, there's a difference between the mouth, the prominence of the mouth, the rugosity, so there's this turgidness that is apparent in the post-transition images, and is particularly apparent in the 3D images. And this is a feature that is repeated in this subject population. One of the things that had nothing to do with fat redeposition, with aging or with fat migrating, was the change in nasal width. 18 subjects. I could look at 18 subjects. 100% of those 18 subjects became narrower at the ale, which is the flares on either side at the bottom of the nose, and they were narrower in the nose by a considerably larger increment than the rest of the changes in the face. 56% of them between 7 and 17%, less than the original dimension. And this is exactly the opposite of what happens when we age. When we age, what happens is our noses droop and they get wider here. So, based on an implicit assumption that the effects of testosterone in the body are also going to be reflected in the face, the facial appearance of a female-to-male transsexual on exogenous testosterone, if given long enough and at high enough dosage, virilizes. These changes are probably due in part to increased muscle mass as a result of the testosterone, but it's difficult to say because of the confounding factors of weight gain and loss and the effects of aging on the faces. What I wanted to do was get at the craniofacial bones, and I was not able to do that because CT scans are not allowed for those purposes. The nasal width reduction is the one result that came out of it that couldn't be tied to variations in BMI or aging. I'm going to go off on a slight path and then I'm going to come back. A lot of people can choose to present an androgynous identity. It's largely supported, often, by window dressing. Hair, clothes, jewellery, makeup. And facial sexual dimorphism can be, to some extent, offset by this. In terms of sexing the face, studies so far have shown us that we're able to identify unfamiliar adult faces in less than a second with 96% accuracy. Most of the studies that have looked at this ability and our accuracy tend to present images that don't have a lot of window dressing, and they tend to use an oval cutout. So the hair is taken away, very often the ears are excluded, and so on and so forth. What I wanted to look at was what it was that tells people a face is male or female. So I wanted to look at feature saliency. And what I did was I wanted to set up an examination of facial ambiguity. So I did an online survey on SurveyMonkey. I took 20 faces with neutral expression, bald heads, a uniform facial perspective, black and white, plain background, and very, very minimal window dressing. There were 401 observers that returned responses and 1,946 written responses, which I had to code manually, about what it was in the 10 faces that informed their decisions on face sex. So the mean rate for correct assessment of face sex for all images was 69.6%, which is appalling if you figure that, 50-50 chance of getting it right. And the rates varied across those 20 faces from 28 to 98%. So face number 3, female, and the percentage of people who got that correct was 53%. Face number 5, female, 42% got that correct. 28%. These 5 faces were the faces that fell into the most ambiguous, the most androgynous category. Face number 11, female again, 55%. Face 14, female, 56%. There was a group that was grouped simply by the rate of accuracy of observers in the 70s range, still pretty appalling. The person in the middle, who is squared with red line, is a assumed genetic male. And this was the grouping, again by percentage of accuracy from observers, of the least ambiguous. And the top left and the bottom left are both presumed genetic males, 98% and 96%. So what came out of my tallying of their responses was that the eyes, the lips, mouth, eyebrows and nose, in order, are what people look at when they're deciding a face is female. You can see that the order, except for the jaw, chin, is the same for the males, except that the jaw, chin is predominant and is the first thing that's looked at and is the deciding factor most of the time. So, allow me to read. The number of times a feature was used for suggesting female as opposed to the number of times it was used for suggesting male indicates that features were not used equally for assigning face sex. So I had some help with the statistics on this because there was an awful lot of information, and to try and make sense of it, that was necessary. The red line is a one-to-one line, and there's a group of features that are clustered around the bottom left-hand corner. The further away from the red line and the further up or the further out means that that feature is more significant for deciding the sex of a face. So what happened was male confirming and female conflicting features were clustered, and female confirming and male conflicting features were clustered into male suggesting and female suggesting classes of features. What came out of this is that there is a connection between the results and ambiguous female faces and FTM faces, and that connection is the jaw, particularly in regards to female to male faces. So out of this data, what came was that the jaw, which is down there in that corner there, the jaw is described as confirming by the observers the face is assigned male. If the jaw is described as conflicting by observers, the face was assigned female every single time. Eyes are up there and that's eyes. So everything on that side, on the left side, is female confirming and male conflicting, and everything on the left side is male confirming and female conflicting. Oh, what happened there? So the relationship between that and the FTM faces is that the most common effect was a widening of the upper jaw, 76% of subjects, and the lower jaw, 52% of subjects. In 24% of subjects overall, this was accompanied by a widening at the anterior jaw and chin, as well as the mid-facial area. For 76% of the FTM transsexual faces, the upper jaw became wider, and for 44%, the upper and lower jaw together became wider. The dominance of this feature as it related to an increase in dimensions indicates that there's an importance it has in contributing to the perception of post-transition FTM transsexual faces as male. One of the things that came out of the written responses, and it wasn't a significant percentage in terms of the proportions, but it was a significant thread because it ran through all of the written responses, was that the observers became quite agitated. They got quite angry. They were angry. I'm not sure why they were angry, but they accused me of altering the images, of trying to con them or trick them or fool them. And they became particularly agitated with face number 10 and face number 16, which is next. Now, I'm going to hazard a guess and say that most of the pictures are of gay people, or looks like a lesbian, and this is in reference to face 10. Presumed genetic male, 77% of the observers got that sex of the face correct. This is where the social elements enter into the study and enter into our perception of the sex and gender of faces. Sexual orientation here is conflated with gender identity or face-sex identity. And that raises questions about the effect of face, sex, and gender as perceived by society, particularly in relation to quality of life for FTM individuals. Face number 16. Now, face 16, presumed genetic male, 96% people got that right, and I thought that was reasonable. And these were the comments. Again, these comments are conflating what is assumed to be a sexual orientation or a sexual identity with the sex or the gender of the face. Face number 8, which had one of the poorest accuracy return rates, male arrogance, no real effort to look female. So in a sense, I think this reflects upon the stage that female-to-male transsexuals go through. Female-to-male transsexual faces transition in terms of passing as masculine-looking very, very quickly. And in a sense, much more successfully, often, than male-to-female transsexual faces transition to looking feminine and passing. But I think that one of the things that occurs is that female-to-male transsexuals go through a very, very difficult period wherein they're not sure of how the world is going to see them. The face is the most important aspect of our visual presentation to the rest of the world. Body shape is important, but we don't tend to go around in public with our clothes off. We don't tend to go around in public demonstrating what we have in terms of genitals between our legs. What we present basically to the public is the face. The face is key, it's crucial to who you are in the world. If there is reaction in a general socialized way to your face, and your face is ambiguous or androgynous, I think that it creates a social conflict and it creates a social barrier to feeling comfortable, to feeling stable, to feeling protected in the world. And I think this is an issue that needs to be looked at more. So when I'd finished with the study, what I was faced with was trying to decide what it was about the female-to-male faces post-transition that made people think they were male rather than female, or an androgynous female, or a difficult female. One that didn't make enough effort to look female, for instance. Even a very feminine-shaped face would presumably be categorized as male by human subjects if there were any evidence of beard growth. And I have to agree with that. I think that's very, very true. But there's something else going on, and I'm not sure what else is going on. People demonstrate a sense of quandary, a sense of not being sure why they think something, but they're quite sure about it. Interestingly, the responses in the Survey Monkey study, I measured their degree of confidence. So depending upon whether they assigned a face in the array, male or female, I asked for their confidence in their decision. People who got it wrong were as equally confident, if not more confident, than the people who got it right. And I think that actually deepens the mystery a little bit about what it is that allows us to tell a male face from a female face. When it comes down to it, the face-sex threshold is very evasive. The most compelling lesson is the sheer difficulty of finding a set of discriminating measures to allocate faces into categories of male and female. And that is amply demonstrated by the Survey Monkey study. And I will leave you with this, I think, rather fascinating image. This is two faces, a set of twins, male and female, spliced together. Thanks for your attention. Any questions?
Thanks very much. Don't go too far away, Gus. There's bad.